So vital signs are vital because they reflect a fundamental physiological condition of the person, and that's why we consider them so important. The classic ones, as you probably know, are blood pressure, respiratory rate, heart rate, and temperature. In the latter part of the 20th century, we realized how important pain was in terms of reflecting how our patient was doing. So we focused a lot more on pain and pain assessment and realized that we could almost consider it a fifth vital sign. It's so important. There's even another added on vital sign, and that is oxygen saturation, sometimes called O2 sat. It's the saturation of oxygen in the periphery on a 100% scale. In some ways, it is extremely helpful to see how our patient is doing. However, it's not classically a vital sign. We've sort of tossed it in because it's so easy to take. Pulse oximeters, the machine that measures SATs, have really proliferated. It's cheap, it's easy, it's not invasive. It gives us a helpful number. So it's very often taken sort of together with the other vital signs. Technically speaking, it's not considered a vital sign, but practically speaking, it is. Temperature. When we measure temperature, really what we're interested in is the core body temperature. What is the temperature inside the core of our patient, which is to say the head, neck, and trunk, or chest and abdomen of our patient. It doesn't matter to us so much if the fingers and toes are cold. I mean, we don't want our patient to be uncomfortable, but that's not as critical as the vital organs. So what we're really trying to measure when we measure temperature is we're trying to get a close estimate of the core body temperature. Generally speaking, it's not advisable to take a thermometer and stick it through the chest of your patient. We don't like that. It's not that easy to get the core body temperature, the actual core body temperature. We're going to get our best estimates of it. There are several different routes you can take a temperature, and it depends on what kind of thermometer you have, and also the patient condition. So we have oral, tympanic membrane through the ear, temporal, rectal, axillary. Becoming really popular in 2020 with the COVID crisis is the kind of thermometer that you can hold in front and shoots a laser to the forehead and measures the temperature with no touch at all. An oral thermometer is very easy to use. It's non-invasive. People don't generally mind putting something in their mouth. But what if you have a patient whose mouth is wired shut or who can't keep their mouth closed? So in that case, another route would be helpful. For each one of these routes, there are guidelines to help us use those machines correctly. So for instance, if you're taking an oral temperature, your patient should not have eaten. They should be NPO, nothing by mouth, no drinking, no eating in the last 15 minutes. Some sources will say 30 minutes. I think science is showing that 15 is sufficient. Why is that? Well, because if I've just had a nice hot cup of coffee, then my mouth might be a lot hotter than it would otherwise be. Or if I've had an iced tea, then my mouth might be a lot colder than my core is. We want where we're taking the temperature to be as close as possible to the core body temperature. For the same reason, if you're taking your patient's oral temperature, you want that tip of that thermometer to be as far back underneath the tongue in the sublingual pocket as possible without hurting them. And you want the tongue to be down touching the thermometer and the mouth to be closed. If my thermometer tip is out next to my teeth, then I'm not getting my patient's core body temperature, I'm getting the temperature of their teeth. Not so helpful. No smoking for a couple of minutes, no eating or drinking, NPO for at least 15 minutes. An axillary temperature is, axilla is the armpit, and if you have an axillary thermometer, I don't have a thermometer with me now, I'm going to use a pen. Let's just pretend. So if you have that tip of the thermometer, you want to put it all the way up underneath the clothes, all the way up in the armpit with the elbow down, the arm down on top of that thermometer. Again, if you have the tip of the thermometer just at the edge, okay, or with the arm up, then you're not getting as good a temperature reading close to the core body estimate as you can. So you want it all the way up in the middle, okay, not anterior axillary, not posterior axillary, you want it mid-axillary, all the way up and with the arm down on it. A rectal temperature is a good estimate of core body temperature because it's almost in the abdomen, really. However, it's fairly invasive. It's hard for some people. It's hard for the nurse. It is very useful for infants, small children who generally don't mind it as much. And then you've got an excellent approximation of the core body temperature. So let's talk about pulse. It's almost always the same as heart rate. Not always, but for the purposes of this course, we're going to consider them the same. So pulse is the number of times that our heart is contracting per minute. And as a beginner, you need to count the number of pulses in 30 seconds and multiply by 2. We're concerned with mainly 3 variables in the pulse in allopathic medicine and nursing. We're interested in the rate, but also we're interested in the rhythm and the force to a somewhat lesser extent. The rate is how many contractions or pulses, a wave of pulse through the arteries in the body in a minute. So you're going to be counting how many pulses you feel in a peripheral artery or the apical pulse in 30 seconds and multiply it by 2. If you've been out in the workforce as an RN, you passed your NCLEX and you've been working for 5 or 10 years and you say you can figure out what the pulse rate in less than 30 seconds, that is fine. But until you pass the NCLEX, I don't want to hear it. 30 seconds and multiply by 2. We are also concerned with the rhythm of the pulse. So we want to know if it's regular or irregular. And a regular rhythm means that there's the same amount of time between each pulse. So is regular. Is irregular, because there's not the same amount of time between each pulse. Now, if you have an irregular pulse, the next question you need to ask yourself is it regularly irregular or irregularly irregular? What? Irregularly irregular means that there's no pattern whatsoever, okay? But regularly irregular means that there's not the same amount of time between each pulse, but there is a pattern to it. So, for instance, not the same amount of time between each pulse, but there is a pattern that you can see. Most common example of this is that most of us will have an increased pulse when we inhale, and then when we hold our breath or exhale, our pulse slows just a little bit. Totally normal. It is an irregular pulse, but it's regularly irregular because it moves with the pattern of breathing. The third variable that you need to measure is the force of the pulse. So we measure this on a 4-point scale. 0 is absent, otherwise known as dead. 2 is normal, so 2 plus or plus 2 is considered normal. 3 plus is strong or bounding. 1 plus is weak, also called thready for some reason, I guess. It feels just like a little thread. Barely there at all, but it's there. Exactly how you tell the difference between a 2 plus and a 3 plus, between a 1 plus and a 2 plus, you need to feel a lot of pulses, and then you're going to get a sense. Where do you have to be able to take the pulses? You need to be able to take the radial pulse. You probably know that. It's at the radius, just proximal to the base of the thumb. The carotid, we'll talk about that more when we do cardiac. There's femoral at the crease of the groin. There's popliteal or popliteal, depending on your pronunciation, behind the knee. There's posterior tibial at the bottom of the tibia near the malleolus. There is dorsalis pedis, which is on top of the foot. And did I forget? Oh yeah, there's brachial. We use that one when we're taking blood pressures. So that's kind of easy. What is a normal pulse rate? Well, for an adult, the traditional normal range is considered 60 to 100. However, there's a lot of science that's been going on in the past couple of decades that show that maybe if someone's pulse is in the 90s, it kind of reflects that maybe it's working a little too hard, and they might have negative outcomes later on. Also, if you have a pulse in the 50s, it's very possible you're just athletic and you've got a low resting heart rate and you're more healthy than otherwise. So there's some sources that are going to say that a normal adult heart rate is between 50 and 90. Others are going to say 60 to 100. I promise not to ask on a test, is 96 normal or not? That would just be cruel. However, you should know that over 100, at least, if not over 90, is considered too fast or tachycardic. Tachycardia is the condition, the noun. Tachycardic is the adjective. What is it to go too slow? If it's under 60 or possibly under 50, depending on who you ask, it's bradycardic. Brady means slow. Don't tell Tom Brady I said that. A child's pulse is faster normally than an adult's pulse. And when they're born, it's really fast. And as they grow up, it gets a little slower, a little slower. There's not like they wake up on their 18th birthday and suddenly it's really slow. No, it's gradual. Oxygen saturation is measured on a percentile scale, so up to 100. It's sometimes called pulse ox or O2 sat. They're usually a little clamp or something that goes onto a finger or possibly a toe. You can get it on an earlobe. That may not be quite as good a reading, because what we're trying to read is perfusion in the extremities. And in fact, the earlobe is cartilage, which doesn't get quite as good perfusion as other parts of the body, so it may not be the ultimate, but you can use it in a pinch. Even on neonates, you're going to see, like in the picture, their skin is so transparent, you can just wrap it around their whole little foot, and that provides a good oxygen saturation. Their little fingers are too tiny. We're hoping that to get an oxygen saturation of the high 90s. If everything is good, A+. We want above 95 or above. You're not going to get an O2 sat of more than 100, or if you do, your machine is broken and you shouldn't record it. Where some people are going to have a reading in the low 90s as their baseline if they have really bad perfusion for some other reason, but it could be significant. It also could be a reflection of a sudden change and a pneumonia or an asthma attack or a pulmonary embolism, so you want to make sure you know what's going on. Anyone under 90, you've definitely got a problem, and you've got to address it ASAP on an emergency basis. The machines are taking the pulse at the same time that they're taking the oxygen saturation, so that's why it's often called a pulse ox. You need to be able to take a pulse without the cute little machine, but you can't take an O2 sat without the machine. It uses a little laser to reflect how much oxygen is going through in the periphery. There's an assumption that if we have good perfusion in the periphery, that there's good perfusion in the vital organs, which is most of the time true. What is blood pressure? Blood pressure is the pressure exerted by the blood on the walls of the arteries as it's flowing through your arteries. The unit of measurement is a force. It's millimeters of mercury. So that's the amount of force that the blood is pushing against the arterial walls as it's flowing through the arteries, coming out of your heart. It's important for a whole lot of reasons, but one reason is it has to have a certain amount of pressure to get to the rest of your body from the heart. But if the pressure is too high, it can do all kinds of damage to us. The blood pressure is regulated by tons of different things, including age, gene pool, exercise, medications, stress, body size, a whole lot of things. And some of those variables are things we can change, and some of them we can't. When we're measuring the blood pressure, there's two numbers, right? The systolic number, that's the higher one. That is when the first pulse is heard, and the diastolic, the lower number, is where the pulse disappears. So what's going on when we're measuring the blood pressure? Let's go back to physiology for a second. Remember that the heart is a pump, okay? When the atria are contracting, the ventricles are relaxed. When the ventricles are contracting, the atria are relaxed, right? So the cardiac cycle moves like that. One cycle is one contraction of the atria, then a contraction of the ventricles. The ventricles are the larger, more muscly chambers of the heart. So when they contract, that's when that blood is being pushed out into the great arteries at the highest pressure, when the ventricles contract. That is called systole. That's where we get the systolic pressure from. It's the highest pressure. The diastolic pressure is the lowest pressure that the blood is under during the cardiac cycle, because the ventricles are relaxed while the atria are contracted. So that pressure in the arteries is the lowest at that moment. How do we take that blood pressure? How do we measure that? If you take your stethoscope and put it gently on top of an artery, it should be a silent event. You're not going to hear anything if everything is healthy. However, if we put challenging pressure against it, that blood, because of the pressure that it's under, is going to start to become noisy. Like white water in a river that's under a lot of pressure because there's rocks and there's a lot of pressure, it becomes noisy. If you take that river further down, when the banks open up and the bottom of the river gets lower, there's the same amount of water, but there's a lot more space, it's quieter. So what happens is, if we put our stethoscope against an artery gently, we don't hear anything, right? But if proximal to that stethoscope, we cut the arterial blood off totally by mounting significant pressure so that there's no blood flow distal to that cuff, you're also not going to hear anything, right? So say the highest blood pressure of my heart is 120 when the ventricles are contracting. And the lowest pressure that my arterial blood is under during the cardiac cycle is, say, 70 down here. When you bring challenging pressure way up above 120, you're not going to hear anything, right? But as you slowly bring that challenging pressure down, at a certain point, it's going to match the systolic pressure that my blood is under, right? At that moment, that blood pushes through because it just can barely make it. You're going to hear a pulse, okay? A loud pulse usually. And then you're going to hear a pulse, pulse, pulse as we're slowly bringing the pressure down. But as that pressure equals to the lowest pressure at which my blood is under during its cardiac cycle, you're going to hear silence again, okay, below this point. Because, again, my blood isn't working so hard. It doesn't have to work hard to get through. So it becomes again silent. The systolic is where we start hearing the blood pressure pulse, and then the diastolic is where that pulse disappears. The systolic number reflects the pressure which my blood is exerting on my arterial walls at the strongest point of pressure during the cardiac cycle, and the diastolic number reflects the lowest pressure that my blood is under during that cardiac cycle in the great arteries. Now, the blood pressure is a low-pitched sound, and for that reason, among others, the best way to take it is with the bell of the stethoscope. Whenever we use the bell of the stethoscope, we want to use a very light touch. If we're pressing down on the skin, then you're effectively making it a diaphragm. So if we are taking the blood pressure, we should be using the bell because it's a low-pitched sound. On the other hand, if you are using the diaphragm and you hear the blood pressure using the diaphragm, it's not wrong. It's just that it might be slightly harder to hear. You're not changing the number. There's a number of other things that we should do or shouldn't do when we're taking blood pressure. For instance, your patient should be at rest, not moving around, and the room needs to be quiet. You'll notice, especially as a beginner, that some people's blood pressure is really hard to hear. And any ambient sound in the room is going to make it a lot harder for you to hear. So turn off the patient's TV, ask them to suspend their phone conversation, whatever it is, so you can have real quiet. You want your patient to be seated with their feet on the floor, not with their legs crossed. If you are taking a patient's blood pressure lying or standing, that can be certainly valid, but you need to document what position they're in. The cuff should be approximately at the level of the patient's heart. It shouldn't be way up in the air, okay? It shouldn't be way down below the heart. Otherwise, that actually changes the number, and it's not a valid reading. The sphygmomanometer, that gauge, should be at your eye level. It shouldn't be way up here or tilted away because the needle is actually over the numbers. If your eye isn't at 90 degrees above that needle, it's going to be very hard to tell what number it's actually pointing to. As a beginner, you really need to put your stethoscope against that patient's bare skin, not over clothes. You'll notice as you start to use a stethoscope that if anything is rubbing against the tube or the lumen of the stethoscope, or there's clothes between the stethoscope and the body, that they can really create a lot of extra sound. We call it artifact sound. That's not body sound. And especially as a beginner, it's hard to sort of separate the artifact sound from the sound you're trying to hear. So bare arm on the antecubital space, the inside of the elbow, when you're taking that blood pressure. Make sure you use the proper size cuff. If someone has a large arm, they need to have a larger cuff. If they are a small child or a very skinny adult, they need to have a smaller cuff. If you're using the wrong cuff, you're getting the wrong number. Now, orthostatic vital signs are a set of vital signs from lying to sitting to standing, or just from sitting to standing. When the patient moves position, our physiology changes. Gravity has an effect on our vessels and the fluid in our bodies. And we need to be able to counteract those effects in an efficient, effective way to adapt to position change. If we're not able to make a position change adaptation well, that's an important reflection of what's going on in our body. So those are called orthostatic vital signs. How we do that is, for instance, we have our patients seated, we take a heart rate and a blood pressure, have them stand up, and then between 1 and 3 minutes after they make their position change, we take the blood pressure and the heart rate again. If someone's heart rate has jumped up above more than 10 points above what it was when they were sitting, and it has not yet settled down after 3 minutes, that's called an orthostatic heart rate. Similarly, if the blood pressure has fallen more than 10 points, systolic or diastolic, and hasn't adjusted after 3 minutes of the position change, they are orthostatic. And that's a helpful thing to know. When a heart rate or blood pressure change dramatically with postural changes, we call that your patient being orthostatic. Also points out how important it is to document what position your patient is in when the vital signs are taken. Respiratory rate in an adult, the normal range is about 12 to 20. Now, some sources are going to say 10 to 20 respirations per or breaths per minute. and that's fine. A child's going to breathe at a faster rate than an adult, and again, it starts a lot faster when they're born and then gradually becomes slower to an adult range. A small child might be kind of 18 to 35 breaths per minute, and then slower and slower during their teenagehood. Breathing too fast or more than 20 breaths per minute for an adult would be called tachypnea. Tachy is the same prefix, meaning too fast, and pnea means breath. So, as you might be able to guess, breathing slower than 12 or 10 breaths per minute is called bradypnea. The condition or the noun is bradypnea. The adjectives are bradypnic and tachypnic. Now, when you're measuring your patient's breathing, you don't want to draw a lot of attention to the fact that you're doing so because we have some control over our breath. And if we know that someone's paying attention to our breath, it could change how many times we're breathing or how we're breathing. So generally speaking, we want to be upfront with our patients about what we're doing, but you don't really want to bring attention to this particular thing until you can say afterwards what you were doing. Oftentimes you can see from across the room, you can count, you can watch their chest or their belly and sort of see how many times it's moving up in a minute, one whole cycle, inhalation and exhalation, and count for 30 seconds, multiply that by 2, you've got your respiratory rate. In some people, it's not going to be quite as easy to see, and you're going to have to move closer. One way that you can get away without bringing a lot of attention to this is that you can be feeling their pulse, and while you're counting their pulse rate, you can have their hand with your hand right over their chest or belly. You're counting for 30 seconds, note that pulse rate, make a note in your head, and then without moving your hand, start focusing on how many times their chest moves up and down under your hand in 30 seconds, and then multiply that times 2. You get your respiratory rate. So there you go. We've got temperature, heart rate, oxygen saturation, blood pressure, and respiratory rate. Now you've got some objective data reflecting vital physiological aspects of your patient's condition. Check out the pain video for more information on the 5th vital sign.